So welcome everybody to the second diabetes presentation. We are doing presentations in honor of National Diabetes Month. Today's speaker is Melissa Zalonis. She is a registered nurse and she is a certified diabetes care education specialist. So I'm going to pass this on over to Melissa and let her take over.
Hello, welcome back, everybody. So as you said, my name is Melissa Zalonis. I'm the coordinator for our outpatient living with diabetes program. And at the hospital, we do, and I mentioned it briefly last week, but we do the outpatient group classes. They're a total of 8 hours. And then we also see folks one-on-one as well. When I say we, I mean there's a team of us that do the group classes. There's a physical therapist or occupational therapist who talks about activity. She'll be here next week. Stacy is her name. And then we have usually a pharmacist is helping teach the classes on the medication section. We have someone who goes over stress management, setting goals. We've got dietitians on the team with us. So when people come in one-on-one, they're generally just seeing the diabetes educator and then the dietitian. But the group class includes several individuals. So that's a little bit on our program. And then I'm going to go over medications, and I don't have all of the medications in here, but we'll go over, I have all of the classes. I just don't have the names of all of them because there's a lot of medications out there. And one thing before I get started is it's always important to remember that lifestyle changes is the foundation of managing diabetes. So you don't want to rely on medications alone. Healthy diet. The dietitian will be here on the 4th day of this session. And then, staying active, stress management, those are all extremely important parts of managing diabetes. The goal when you have diabetes is that your hemoglobin A1C stays under 7%. Are you guys familiar with what a hemoglobin A1C is? Okay, so the hemoglobin A1C, which is an average blood sugar over a 3-month window of time, gets reported in a percentage as well as an estimated average glucose. So the percentage, the goal is to keep it under 7. Now, if it's staying under 7%, then we know that whatever lifestyle you're leading and whatever you're doing is working well to manage it. But if you're eating as healthy as you can, you're staying as active as you realistically can, and that number keeps creeping up, then that's when it's time that medications might be beneficial. So ultimate goal is keeping that sugar as close to normal as possible, because as Linda was saying last week, those elevated sugars, too much sugar in the bloodstream is going to damage those blood vessels over time. So ultimately the goal is keeping it as close to normal. Oops, you might want to take my computer out because it's not turned off. And
I was going to see if that was click advancing.
Okay. Which one did you hit, up or down?
To the right. You might just have to click on this again, but it will shift.
So prescription treatment of diabetes includes prescription medications, medications for diabetes. And these medications are directly affecting a person's blood sugar. And sometimes they're known as anti-hyperglycemics or anti-diabetic medications. They can be pills, tablets, pills or tablets, and injections also. And then usually people are also on what we call supportive medications for other comorbidities that people may have. Other health conditions might be hypertension, high cholesterol. So that's not too uncommon to see those also. So we're going to talk about the different types of oral medications and injectable medications as well. And there is a lot of information, and a lot of you may not be on any of these medications, but it's a possibility that, down the road you may need one. This is just kind of a brief timeline of diabetes meds over the years. And I think the thing that really stands out is how you can see in the last 2 decades, there was a lot of research, there's been a lot of research done and a lot of newer classes of medications that come out. Now, in 1922, that was the first time that insulin was administered to a human. And the scientists who came up, figured out how to make insulin actually won the Nobel Peace Prize. And it was really a miraculous discovery at that time, because insulin is a hormone that we need to survive. So folks who had type 1 diabetes and weren't making any insulin, this was immediately a lifesaver. So 1922 was when insulin was first administered. And then down the road, you see like 1956 was the first sulfonylureas, and we're going to go over all these. I don't expect you guys to remember this chart, but the important thing is that a lot of these just came about in the last couple decades. And these medications all work, each class works differently. And there is no pill, there's no capsule, there's no tablet that is insulin. So that's a question we get all the time is, can I take insulin in a pill? Or people think that the pill they're taking is insulin. But insulin's a hormone our body makes, and science has yet to figure out how to make it in a pill. So, so all of the oral medications, which are used to treat type 2 diabetes and sometimes prediabetes, affect different areas of your body that are helping to regulate sugar. So some of these medications work on fat tissue. That's what adipose tissue is. Some of them are working on our skeletal muscles to help improve the uptake of sugar. Some of these medications work directly on our pancreas, which is where insulin is made. Some of them work on our kidneys, our liver, and our intestines. So they, all of these classes of medications work on several different areas of the body. One of the most common oral medications for diabetes is metformin. And this is usually first-line therapy for somebody who has diabetes. Metformin has been around for a very, very long time, actually many, many years ago. It was derived from the French lilac plant, actually. So it's been around for a very long time. And what it does is it helps your own insulin to work better. So it helps improve insulin resistance. And another thing it does is our liver stores sugar for times when we need it. So if the liver is breaking down more sugar than necessary, this medication can help suppress that. So it's helping to improve how well a person's own insulin is working, as well as suppress the liver from releasing too much sugar. And so overall, what it does is it increases the effects of insulin. It's very common. A lot of people take it, and usually people stay on it long term. We don't typically take people off of it unless they have renal issues. Our kidneys have to be able to excrete the byproducts of these medications, and if your kidneys aren't filtering very well, then you may hold on to those byproducts for too long, and that can put you at risk for very rare complication called lactic acidosis. So it's a pretty common misconception. People think that metformin causes kidney damage, when in fact, it's not the metformin that caused the kidney damage. It's more than likely uncontrolled diabetes or hypertension that led to that kidney damage. And then once a person's kidneys aren't filtering as well, it has to get to a certain level, and then we take that medication off. But otherwise, it's usually kept on board long term. The biggest side effect of metformin is that it can cause nausea, GI upset, and diarrhea when it's first started. So that's very common, but if we start people at a low dose and just let their gut get used to it for about a week or two, then we can titrate it up. And folks can take up to 1,000 milligrams twice a day. So that's usually first-line therapy. One other good thing about this medication is it's on the $4 list. So some of these medications I'm going to talk about are very expensive, and we'll address that at the end. But metformin is one of the ones that's $4 cash pay, or I think $10 for a 3-month supply. The next class of medications are called sulfonylureas. Some of the names, some of the drugs that you'll find in this class, and again, this isn't all of them, but glipizide, glyburide, glimepiride, these medications are actually helping your pancreas to secrete more insulin than what it normally would be doing. And because of that, though, one of the side effects, or two of the side effects that we might see with this medication is hypoglycemia, which is low blood sugar. And low blood sugar is a medical emergency. Have any of you ever had a low blood sugar? Yeah, I see one person nodding. Low blood sugar is a medical emergency. Our body has to have glucose to function. Our brain, our nervous system needs that glucose. If the sugar level gets less than 70, that's too low. And so the nervous system sends out signals such as it make you get really hungry. You might get a little bit confused. People get hangry, they get irritable and hungry. Those are all signs that the sugar is getting too low. And if it is too low, then a person does need sugar to get it back up. Not a lot, but maybe like 4 ounces of juice, something that absorbs very quickly to get it back up. But because this medication is telling your pancreas to secrete more insulin, then that person is at risk for getting too low. And the other thing is weight gain is common with this. Now, if a person's leading a healthy lifestyle and watching their diet and staying active, then they probably won't see that much weight gain. But insulin's helping our body do several things. And the main thing is it's either taking that glucose from our bloodstream and it is storing, or it is allowing us to use it as energy, or the insulin is helping us take that excess glucose and store it as fat. So that's what insulin's supposed to be doing. Our sugar level goes up, and then insulin helps us to get it back down. It takes that glucose out of the bloodstream. We either use it as fuel or we store it as fat. And because this class of medication is actually telling your pancreas to make more insulin, then of course it's going to help you store any excess glucose away as fat. So that's kind of a downside to it. We also use caution with our elderly folks because of that hypoglycemia risk. And then anybody who has like chronic kidney disease stage 4 to stage 5, which they would be on dialysis at that point, we wouldn't want them on this medication either. And again, that's because they're going to not be able to excrete it as quickly, and that puts them at an even higher risk for getting too low. This is also on the $4 list. So for folks who don't have insurance or people who are struggling to pay for all their medications, that might be a reason that we start somebody on this one. We used to always do Metformin first, and then we would try a sulfonylurea, but now with all the newer classes of medications out, we don't have to go to this one. We can try some others. There's a class of medications called GLP1 Agonists, and what this stands for is glucagonlike peptide. You can remember that. That is a hormone that our gut makes. When we eat carbohydrates, our intestines release this hormone called glucagon-like peptide into the bloodstream. What this hormone does is it helps to regulate blood sugars after eating. It also helps to make us feel full. And this particular class of medications used to only be injectable meds, and we'll get to that, but this one is a tablet. So this is a GLP1 that's in tablet form. So when a person takes this, it's going to help control those sugars after eating. It's going to help them to feel full. And therefore it might even aid in a little bit of weight loss as well. This class of medication, the biggest contraindication for this would be somebody who has a condition called gastroparesis. Have you guys ever heard of that? People who've had diabetes for a long time, and if it's uncontrolled, this is a complication that may occur. Gastroparesis is where the stomach, the nerve that goes to the stomach, our stomach should grind up our food for us, and our nerves tell our stomach, those muscles, to contract and do that. If the vagus nerve is damaged, then the stomach may not be able to digest that food as quickly as it should. And because this medication slows down gut motility, we would not want to use it in somebody who already has slowed gut motility. But very effective. Some of the side effects can be maybe nausea, headache, low blood sugar, although that's not real common. And then we have what's called DPP4 inhibitors. So I always talk about the GLP first, because the GLP is the hormone that your intestines are making. That hormone's only in the bloodstream for a very short period of time, because what happens is this enzyme called DPP4 comes and breaks it down. So if we inhibit that, if we prevent that enzyme from breaking down the GLP hormone, then we hold on to it longer. And many people with type 2 diabetes aren't just deficient in insulin or have insulin insufficiency. they also are deficient in some of these other hormones as well. So this can be a really good class of medications for some folks, especially those people who say, no matter what I do, no matter what I eat, I always go hungry afterwards. I just don't ever seem to feel full. Well, that GLP med I was talking about, that actually helps a person to feel full sooner. It works on the brain, the satiety center, telling us that we've had enough to eat. So this particular class of medicines, it's working on the enzyme that breaks that GLP down. So indirectly, it's helping to control those sugars after we eat as well. And some of the side effects are pretty minor that were reported during the research studies, but stuffy nose, runny nose, kind of like some minor flu-like, or not flu-like, sorry, cold-like symptoms. But typically people don't have any problems with that. I did just hear from a physician last month. I haven't talked to our rep for Januvia, but I did hear that Januvia is now on the generic med list. So that's good because this is one of those class of medications that can be pretty pricey. They work well, but you gotta be able to afford it. And then this is the newest class of oral medications, SGLT2 inhibitors. So, and it stands for sodium glucose-like transporter 2. So there is this is in your kidneys. When your kidneys are filtering the blood, it's normal for them to reabsorb sugar. We need that because otherwise we would urinate out all of our sugar as it was flowing through the kidneys. So as that urine flows through the kidneys to be filtered, the body reabsorbs that sugar. Now, once the sugar level gets over a certain level, like over 200, we might start seeing sugar spill into the urine a little bit. And then as the higher the sugar gets, the more we might see in the urine. But what this does is it helps prevent the kidneys from reabsorbing as much sugar. So it basically causes you to urinate out more sugar than you would normally. You have to, women especially, have to be mindful that if you're urinating out more sugar, then it does put you at a little bit higher risk for developing a UTI or yeast infection. So we always tell our patients just be mindful of that. Because if you do develop an infection, then that can raise your sugar too. So you just gotta watch out for those signs and symptoms. These are pretty pricey still. And we'll talk about some ways to save costs here at the end. But SGLT2, so that's probably one of the newest class of meds. Invocamin, Farxiga, Jardiance, those are some of them. I think there's a couple more that have been approved now though. And then what's called the TZDs. These are, we don't hardly ever prescribe these anymore. I don't see them prescribed that often. And I think a lot of that is just because we do have some newer medications out there that have been proven to be more safe and more effective. Now, folks who do take Actos Inhibitor, or who are still on it, they typically do get pretty decent blood sugar control with it. And how this one is working is it also helps improve insulin sensitivity. And then it also helps protect the insulin producing cells in the pancreas. But if a person has heart failure, which many people with diabetes do, the #1 complication of diabetes is heart disease. Because if you have elevated sugars, it's going to damage your blood vessels over time. And so that just makes sense that cardiovascular disease would be the #1 complication. So if a person has liver problems though, or heart failure, then this medication is definitely not one we would want to put them on because it can lead to excess fluid retention, and it can also lead to some weight gain, macular edema, bone loss, and it can actually worsen the heart failure. So we don't usually see this one too often anymore. Maglitonides, I honestly, in the 13 years I've been doing diabetes education, I haven't seen Maglitonides prescribed. But what they do is they stimulate the release of insulin from the pancreas. What'd you say? No, it's okay.
I was glad to see something that he's not taking.
Oh, okay. So what this does is it stimulates the release of insulin from the pancreas, like the sulfonylureas do that too. And because of that, one of the side effects could be hypoglycemia. So we have to use that with caution in some individuals. Now, earlier when I mentioned the GLP1s, Ribelsis was on there, and that's a tablet, but most of the GLP1s, the glucagon-like peptides, are going to be an injection. And I'm sure you guys have heard of somebody on one of these meds or seen a commercial. The Bydureon, Victoza, Trulicity, Ozempic, these are injectable medications. People often think that that's insulin, but this is not insulin that they're giving themselves. So it is an injectable, but you're injecting a different hormone. You're injecting the glucagon-like peptide hormone. And again, it slows the digestion of food in the stomach, so it helps with those blood sugars after you eat. And same as with the pill, you know, it can cause nausea, which makes sense. If you're slowing down the gut, then for some folks that can make them feel a little bit nauseous, headache, low blood sugar. But people also get some weight loss benefits out of this too. And they're very common, but again, price is usually the issue when it comes to being on these medications. And just a little bit more on the GLP agonists. They increase insulin secretion, decrease the amount of sugar that's secreted from the liver. It delays that stomach emptying. And then you can use it with diet changes too to help reduce some of the side effects. And this is just a quick view of how those GLP-1s are working in the body. So they're doing this particular class of medications is working on many target areas. You know, within the brain, it's helping you to feel full. In the heart, it helps to, it's been shown to help decrease some blood pressure and increase heart contractions. And then kidneys, it helps with that as well. The pancreas, it helps promote a little bit more insulin secretion. So it's working throughout on many different target areas. And then we'll jump to insulin. So there are many different insulins out there now. I just categorize this into two slides, what we call basal insulin and then bolus insulin. So basal basically means a steady rate of insulin. Our pancreas is always releasing some insulin when we need it, even if we're sleeping, times when we're not eating. We're still having some insulin release. So this basal insulin, it's also called long or intermediate acting, typically is only given one time a day. There is some situations where we might have a person give it twice a day. It's not dependent on food. So people usually take it at bedtime. And if not educated properly, then a lot of people will go to bed at night and their blood sugars might be in the 90s, and then they'll think, well, I don't need my insulin. And so they won't take this basal insulin. And what happens is they don't have that background insulin on board for the next 24 hours. So even if a person's blood sugar is good at bedtime, if it's, you know, even a little on the low side, then they still need to take this because it's providing them a slow, steady release for the next 24 hours. So that's what we call basal insulin. Some of the insulins that fall into this category are Lantus, Levemir, Tresiba, Toujeo. So there's several of them out there, but they're long acting. And then there's also the intermediate acting insulin would be NKCH. That's been around for a very long time. It is given twice a day. And for financial reasons, a lot of people are moving back to NPH because it's much cheaper.
Then when you get the $24
You can, yep. Yep. And then there's bolus insulin. So bolus insulin is also called short or rapid acting. There's actually now an ultra rapid acting one too. So short acting insulin, these insulins are generally taken before a person eats. So the basal insulin gives you a slow, steady release, but this particular type of insulin, it works much quicker. It's working on the food you're about to eat. Now, occasionally we might have people get very small doses of it to help correct a high sugar because it works right away. You can't correct a high blood sugar with a basal insulin like Lantus or Levemir because it doesn't peak. It's a slow 24-hour release. But this one, you can correct the high blood sugar right away. So the short-acting insulin would be like the regular insulin that a person would take 30 minutes before eating, which you also can get at Walmart. We'll talk about that. And then the rapid-acting insulins are like Novolog, Humalog, Apidra, and then Fiasp is a new one. That's the ultra rapid-acting one. It works in about 3 minutes versus the rapid-acting works in about 15 minutes. But all of them are typically given before meal. Otherwise, they're given in a small dose just to correct a high sugar. So it depends on which one you're prescribed, and I'm going to talk about that here at the end. And then there is also supportive medications. So it goes back to talking about hypertension and high cholesterol, which goes, when we do diabetes care, we're looking at the whole picture, not just diabetes. It's not uncommon for people who have diabetes to have high blood pressure also. And so they may, a person may be prescribed ACE inhibitors or ARBs. These are pretty common ones. So like a lot of people have heard of lisinopril, Prinabil, enalapril. These medications are helping to lower the blood pressure. And sometimes lisinopril, one of these ACE inhibitors, are also started just to help preserve kidney function, to help protect the kidney over time with diabetes. Your kidneys have very tiny blood vessels in the back of them. So do your eyes, your feet. So those blood vessels are very small and they're fragile. And, keeping blood pressure under control, cholesterol under control, sugar under control, those are the things going to help protect those blood vessels. And then there's also calcium channel blockers too, that we can try with hypertension. And most of them have been around for a long time, safe, at low doses. And then for high cholesterol, elevated cholesterol is common in folks with diabetes too. We always talk about insulin playing a role on blood glucose metabolism, but insulin also helps our body to store triglycerides or fatty acids. So insulin plays a role on our cholesterol as well. And if you have insulin resistance, then you may have some issues with your cholesterol levels too. Statins are usually prescribed if somebody has high cholesterol. And some of the names are atorvastatin, lovastatin, pravastatin. They work by blocking a substance your body needs to make that cholesterol. And then overall, it'll lower it and lower your risk of stroke and heart disease as well, because high blood pressure, high blood sugar, and high cholesterol, all of those combined put you at high risk for heart disease and stroke. So we want to manage all of them, not just the blood sugars. And then, people ask us a lot too about herbal supplements. There are some herbal supplements out there that have some good research behind them that do show to help improve insulin resistance and lower blood sugar. They're not going to be something though that's going to treat a blood sugar of in the 200s, 300s. If a person has pre-diabetes, a little bit of insulin resistance going on with that, then they might be able to do some herbal supplements. But with all the information that's out there, and the competition between companies to sell products, just always make sure you run it by your pharmacist or your doctor if you're going to start a supplement, especially if you're on several medications, because those supplements can interfere or might be contraindicated, with some of the medications that you've been prescribed. And then that's it as far as the PowerPoint. The cost of these medications is the number one thing that I really want to talk about. Now, when we see people in the hospital for uncontrolled diabetes, I don't know the actual percentage, but the majority of people who are not managing their diabetes well, it's because they can't afford it, whether they have insurance or not. It's because they can't afford it. So for folks who have no insurance, if they're self-pay, then, if they have to be on insulin, that means they need to check their sugars 4 times a day. That also means they need follow-up care. Well, that's really pricey if you're homeless or, you don't have transportation. There's so many barriers to all of this. If they were to do the insulin at Walmart, like you were talking about, there is insulin at Walmart. It is the NPH, which is an intermediate acting insulin, twice a day. And then there's also regular insulin that a person can take with meals. It's $25 a bottle, cash pay. However, there are some people that have really high insulin resistance and they may need 2 of those bottles a month. So now you're looking at $100 instead of $50 for both of them. Then there's the cost of the insulin syringes. There's the cost of the glucose testing supplies. So it can be very, very expensive. There are a lot of resources out there, but many people don't know that you can go to Walmart and get that insulin for $25. If you were to buy a bottle of the other stuff, cash pay, a vial, you're looking at maybe $300 to $600, just depends. And then the insulin also comes in pens. Have you guys seen insulin pens before? So a box of insulin pens for any kind of insulin, it's generally going to be around $500, $600. And you get 5 pens in a box. So you get a little bit more volume than you do a vial. And you don't waste as much. But again, those pens are really expensive. If you don't have insurance, then you can't do like Humalog and Lantus. The regular and the NPH, it does come in pens now. They just started doing that last year is when I found out about it. So the regular and the NPH insulin, it's $42 for a box of pens versus $500 of the other stuff. And even, I would say most of the patients that really struggle with this are some of our patients on Medicare who have very high copays. And unfortunately, Medicare folks cannot use copay savings cards. They can't use vouchers. They may be able to use some like 1 month's, free supply voucher, but generally Medicare, Medicaid, TRICARE, VA, those patients cannot use copay savings cards. And so if I call a prescription in for Humalog and Lantus, because that's what we started them on at the hospital, it might say it's preferred. That's all it tells me. It's preferred on your plan. But when I call the prescription in, it might be $175 copay. And the majority of folks can't afford that. And so if they can't afford the copay, then we switch them to the regular and the NPH, which would be $42 instead of whatever their insurance is having them pay on the other stuff. So it's very expensive, and there's a lot of resources out there. I think there's even many physicians and nurses who don't know those resources to tap into because they're not doing it every day. My colleague and I, we do, we work with this every day. So if you guys are ever having a problem affording your medications, or somebody who is, just have them give us a call, because that truly is the #1 reason that we see anymore that people aren't managing their sugars well. Sometimes people with Medicare will be doing fine throughout the year, and then they hit that donut hole and they go to pick up their insulin, and now all of a sudden it's $800. And, the physicians may be able to, give some samples until you get out of the donut hole, or again, they could transition you to regular NPH and do something that's more affordable. Same. Mm-hmm. Yes. I think, yes, I've seen some before. Like that have VA insurance, maybe. Is that what you're? Okay. Yeah. Mm-hmm.
So I'm a retired military, and I get all the way to 6 pharmacy and months out at Fort Leavenworth.
Okay. Okay.
So to speak. There's 2 meds. Ozempic, which is an injectable, and Jardiance, which is a pill, which they won't process out there unless a unopposed doctor prescribes it, which makes absolutely no freaking sense.
So
The net effect of that is Jardiance is a $20 copay for 90 tablets, and the Ozempic is $60 for 3 pens, which is 12 doses.
Okay. So I can't speak exactly how Leavenworth works, but there are many places that get grants, that have grant funding, or nonprofit organizations. We've got some pharmacies out in the rural areas, and then here in town, what we call our safety net clinics, like Samuel Rogers, Truman Med Center, Swope Health. These are places that are generally for uninsured folks. Now I know you have insurance, but I think this kind of ties into what you just said. This does pose a challenge for me at the hospital. If I have a patient who, for example, is already established at Sam Rogers, okay, and we want to put them on whatever insulin it is, they can't take that prescription from a provider at the hospital, a hospitalist, and take it to Sam Rogers. It must be written by a provider at Sam Rogers. And I believe that has to do with the grant funding. Or however those programs are funded, they want that provider at that facility to be prescribing it. On some occasions, I'm able to get a hold of the pharmacy over there who can get a hold of their doctor to go ahead and just transfer the prescription, write it in their name. It's also the same thing with VA folks. Some people are established at the VA and they can get their medications at a very decent cost, but if they come to the hospital and this is new to them, and when you're prescribed insulin, you need it as soon as you're discharged. You can't wait a few days for it. So that poses a barrier. It's a challenge for us because basically that person to us is like cash pay as they walk out the door because they can't fill that prescription at the VA right away. So there's a lot of challenges with it. And for those folks, we often do like the Walmart insulin until they can get in with their provider. But I suspect it's similar to that at Leavenworth. I suspect that's why it has to be an on-site provider that has to write the prescription.
I was using Express Scripts.
Uh-huh.
And then for some reason, we decided I needed a refill, so my doctor had to replenish the script. So I had them send that 2 months at London.
Mm-hmm.
They filled the prescription. And then I went back when that prescription expired and still had the same label on the bottle that for months. I said, no, we can't do it. So it just,
They did that mistake.
Yeah.
it just makes no sense.
I know, and unfortunately, there is a lot of it that makes no sense.
And I mean, I'm lucky enough that I can afford to pay the.
Right, but yeah, and not everybody can. And those copays add up. Sometimes the copay for some of this stuff is $40, and that doesn't sound like much. But when you've got 10 medications and you're trying to afford it all, it can get pretty difficult. And insulin is probably, I would say it's probably one of the most challenging for people to get sometimes, an affordable cost. And usually it's because they aren't aware that there's something more affordable at Walmart. But if for people who have commercial insurance, if they do have a high copay, so if you have Blue Cross Blue Shield or Cigna, and you have a high copay, there's usually a copay savings card that will bring it down. So like the makers of Lantus, you can get Lantus usually for $0. There's another long-acting called Basaglar. That one you can usually get for $5 if you have commercial insurance with the copay savings cards. It's our uninsured folks and our Medicare folks and government insurance people who usually struggle the most, unfortunately. And the same goes for glucose meter testing supplies too. If a person's using a name brand meter, the test strips for that name brand meter are really expensive. They're usually about $1 per test strip. Now there is generic meters out there and more have come out. As far as I know, Walmart still has the most affordable one, and Sam's Club. And I think Costco has one that's pretty cheap too, but you don't need a prescription to buy glucose testing supplies. You only need the prescription if you're submitting it to insurance. But if somebody wanted to go out and buy a generic meter, they can just go to Walmart and get the Walmart Prime for $9. And then you can get 50 test strips for $9. And I've had patients who have Medicare, and because they're on oral pills, they're only allowed like 2 test strips a day, but maybe they want to check more frequently, or, you know, maybe they're ill and they want to check more often, and then they run out of strips before it's time to refill. So during that time, there's some folks who will just go buy a generic meter as backup. You know, but none of these medications work well if we can't take them. You know, if they're too expensive and people are rationing insulin or taking their, you know, expensive oral medication every other day, then it's not as effective as it should be. And I hope, you know, by the time I retire from doing this, that this isn't an issue, but this is the biggest issue now is cost, and all the barriers to getting what we need, you know, to manage those blood sugars. So, that, you know, a lot of those newer classes of medications like the Jardiance and then the SGLT2s, the Invokana and Farxiga, they're really expensive too. I mean, you're talking $300, $400, $500 a month. I do always tell people, make sure you're checking with your plan, you know, find out what is most preferred on your plan. And then occasionally you might even be able to find it cheaper at another pharmacy, just running it as cash with a good RX card. So sometimes we try that too. But there's a lot of barriers to taking some of these medications. So, do you guys have any questions? No? Okay. Well, please, if you ever do have questions about cost of meds, or you know somebody who's struggling, just tell them to call the diabetes nurse at the hospital, because we can at least point them in the direction to get those resources. All right. All right. There's only 2 of us there, so if you ask for the diabetes nurse, we share a voicemail, so you don't have to remember my name or anything. Just call the main number and say, can I leave a voicemail with the diabetes nurses? There you go. See, you remember it better than Linda and I do. CDC, yes, stands for Certified Diabetes Care and Education Specialist. It's a big title. All right. Well, thank you guys for attending.